So, respected chairperson, and good evening, everyone. In fact, sir, to your information, I have called all they are the Akanjyoti team.
Yeah.
So,
God bless you all.
so the topic is quality assurance in a high volume cataract surgery. Quality is never an accident. It is always the result of intelligent effort. It is a general perception that quality and quantity don't go together. But it all actually depends on the mindset of the individual or an organization. And Akhan Jyoti is a high volume setup, which has just been started in the year 2006 with a 30-bed eye hospital and 7,000 surgery in the very first year. And now we are 375 bed eye hospital, and we are operating about 76,000 surgery per annum. And apart from that, we have a women empowerment program where the rural girls are taking the education at our center. Right now, we have a 22 vision center and 5 surgical centers. And by in next 4 years, we are looking forward to have a 1100 bed eye hospital with a upcoming 750 bed center of excellence. In a rural, it will be a first of its kind in the rural backdrop. So, is there any rationale for a high volume cataract surgery? The 2.2 billion people are visually impaired across the globe, and among that, 1 billion needs they are not either have been attended. So, cataract continues to be the leading cause of blindness and severe visual impairment. WHO promotes the high volume surgery to eliminate the backlog of blindness. And recently, last year in the May, the Health Ministry of India has convened a meeting that another 10.3 million of cataract surgery are required to eliminate the backlog created by the COVID pandemic. So there is a rationale for a high volume surgery. And so, is there any rationale for high quality? Yes. If we have a literature search, then across the globe, there are a lot of variation in the visual outcome of the cataract surgery. If we go for the sub-Saharan African country, then there are 40% of the patients, they don't have a good visual outcome that is below 6/18 as per the WHO benchmark. And even in India, the 37 to 74.6% the visual outcome in general post-cataract surgery. And apart from that, these are the reported cluster outbreak across the country. It's the figure of the India only, and these are the reported, and there are various unreported cluster infections as well. So quality is an essential component of universal health coverage, where every people should have the best quality of service who access the service without suffering the financial hardship. The basic principle of quality assurance is, it is basically oriented towards the how robust your system and the process, and it meets the needs and expectations of the patients. And it uses the data to analyze the service delivery process, and basically it encourages the teamwork to improve the quality. Quality is the simplest language, doing the right thing, right first time and every time. So it is not a one-time event, it's a cyclical process, and there is an incremental process, and it should be self-motivated. And to implement the quality, every organization should have its own quality policy. This is the quality policy of Akhan Jyoti, which should be aligned with your vision and mission. And there are 8 elements of the quality as per the WHO, that it should be an integrated, people-centered, not only patient-centered, employee-centered. It should be safe to the patient, timely, equitable, and it should be accessible to the entire community, and it should be efficient and effective. So the major drivers of quality at Akhan Jyoti are, and Akhan Jyoti, I will just, it's like a case study, but it applies to everything. It basically depends on the how you inculcate the culture and the value. So it's the role of leadership. And the second thing is the infrastructure, the building, the capacity of the bed, the number of the operation theater, the equipments, how robust they are, and all the facilities, they are compatible with the, you should strike the balance between the demand and supply. And there should be a robust system and protocol for each critical steps. We should encourage the best practices, and there should be, we should strive for the continuous improvement by fostering training and training. So to ensure the quality, it starts from the first contact with the patient, that is outreach and primary vision center. And we should have a defined care pathway. Of course, once the patient arrives, the comprehensive eye examination at the base hospital, you should have a checklist, standard operating procedures, the guidelines, the protocols, and throughout we should adhere to the infection control policy and the safety policy. And you should always measure the outcome to ensure the follow-up. It's not moving? So how does the outreach? Outreach does not only help in the demand generation, it also helps in ensuring the follow-up and referral to the patient, timely referral to the patient to the base hospital. If you have an integrated teleophthalmology, then it further substantiates the quality as Dr. B.N.R. Subudhi was talking about. And once the patient arrives, if there is a defined care pathway, then it facilitates the flow of the patient because you have to deal with the high volume. And the lean management, this concept has come from the Toyota Motor System, where you eliminate all the non-value added waste and you facilitate those tests or procedures which adds to your focus. Like doing ECG or like doing routine test in all ophthalmology, you don't do. So you stick to the blood sugar random or like that. So there is no replacement for the comprehensive eye examination. So you should do the detailed eye examination at the base hospital and all the pre-operative assessment. Before that, the verification, because you don't need to do any error in identification, and case selection. The proper case selection determines the visual outcome. And at this time, you highlight and segregate all the complex cases and the eyes, those who have a ocular or systemic comorbidity, prioritize them, schedule and plan beforehand, check the requisite supply for the surgery beforehand, inform and discuss with the entire team. So you should have a surgical protocol. The most important thing in the operation theater is the discipline, attitude, and how the team works in the sync, because everything is orchestrated. And again, you reconfirm the right eye, right IOL, right procedure, right patient, and have a real-time documentation so that you can monitor later on. And in a high volume setup, all the steps, whether it's surgical steps or the complication management or the training procedures, it should be standardized so that you can monitor. If you are having a training protocol, then it should be supervised and encourage the wet lab and simulators. We have eyesight simulators. And your operation theater should be ready for any kind of ocular complication or medical emergency. So check for the vitrector, check for the iris hooks, CTR or oxygen, emergency trolley or whatever. And don't do any septic cases in a main operation theater. These are the operation theater checklist, the pre-operative checklist we are using. And you can always find it in the other side, AIOS, WHO, the American Academy of Ophthalmology. This is a surgical safety checklist. Before patient enters into OT, once patient finishes, you finish the surgery, once the patient leaves the theater. And the second thing, the adherence of infection control. So the most important thing is how sterilization and how your infection protocol is there, infection control protocol. So there is a layout of operation theatre. It should be segregated into outer zone, clean zone, aseptic zone, and disposal zone. And second thing is you should have a proper central sterile supply department with a proper cleaning protocol. And third thing is you should have a surveillance and monitoring mechanism. It should be a regular, and sometimes it should be, you should visit without information. The operating room environment, the air, surface, water, the culture, weekly culture of the air, fortnightly culture of air, and the monthly culture of RO water. You should check the sterilization process by logbook, maintaining the logbook. How effective is your sterilization? By using the chemical indicator or sometimes biological indicator. You check the surgical supply. Any kind of surgical supply you are using for the first time, you should send it for the culture. If it is okay, then use that batch. If you have any kind of a surgical site infection or inflammation, there should be a reporting and addressal mechanism. You should have a hospital infection control committee who will do the root cause analysis and the corrective and preventive action. And the next thing comes the safety of the patient. So for ensuring safety, we should create the awareness about the safety across the entire stakeholder of the organization, right from the patient to the entire staffs. And you should define the safety goals. There should be a culture of any kind of incident reporting, sentinel event or adverse event or near miss report, and then do the root cause analysis. Why did it happen? Go into the root cause, then do the corrective and preventive actions, and once you settle the thing, reinforce the same thing. So these are the safety goals: ensuring correct patient, correct eye, correct procedure, and the correct intraocular lens. Prevent mortality and morbidity due to systemic complication. Prevent hospital-acquired infection by hand hygiene, by all kind of septic and disinfection procedures. Eliminate medical and diagnostic error.
Sir, please sum up, sir.
Ensure physical safety in the bathroom, ramp, use the ramp, and ensure follow-up. Time ho gaya, sir? Okay, thank you, sir. This is the outcome and benchmarking. So in the outcome, you should have a monitoring system, and you should do it the WHO benchmarking. So these are and it's not about the visual outcome, the overall satisfaction of the patient. Document everything right from each and every steps, guidelines, protocols, document well. Improvement in quality is day-to-day work. Both clinical and non-clinical care affect the quality of service. Quality can be improved in a small, affordable. Cleaning doesn't take a lot of money, but having a femtool takes a lot of money. And know your limitations. Strong leadership and culture development. Quality is critical and achievable in a high volume setting. Thank you. Sorry, sir.
Thank you, Podar. No issue.
Thank you, sir. Dr. Podar, अच्छा, Dr. Nupur Parekh हैं? Next speaker is Dr. Nidhi Pandey. Glaucoma blindness, are we contributing?
One thing I want to ask Dr. Podar, that your topic was centered on the hospital facilities only.
Yes, sir.
Not for the patient's quality.
Yes, sir.
Patient post-operative quality.
Yeah.
But it is only for the hospital quality. But what about the patient's operation post-operative quality?
Yes, sir. Actually, I had the slide. In fact, we summed up the last slide. We measure the post-operative visual acuity first day, and after 4 weeks, anytime the patient comes, we ensure the maximum follow-up. We have a follow-up of about 70 to 75%. And we take the we have a benchmark. We are near
yes,
to the.
I know that you have to show the slide that it is the WHO benchmark.
Yes.
But it is the benchmark is the post-operative result should be the plus minus 0.5 diopter post-operatively in 80% cases.
85%.
And plus minus 1 in 65%. So what is your results, institute's results?
WHO guidelines sir बोलता है कि first post operative day your good vision that is below 6/18 better than 6/18 should be around 85%, and our result varies between 80 to 89%. और best corrected visual acuity के बारे में बोलता है कि your good visual outcome should be more than 90%.
Okay, thank you.
Thank you, sir. Dr. Nidhi Pandey, please.
I'm leaving this hall, please. They will carry.
Respected chairpersons and the esteemed audience, a very good evening to all of you. At the outset, I have to thank Dr. Partha for giving me this platform to share my views on this very important topic. So, in spite of the great strides that have been made in the diagnosis and management of glaucoma, we still see patients, lots of them, coming to us with advanced glaucoma, and the glaucoma blindness is on the rise. While there are some patient-related factors which are responsible for this, we are all aware of these factors, but are there some patient care-related factors as well which are responsible for the increasing glaucoma blindness? To answer this question, we did a small hospital-based study on 50 adult patients who presented to us with advanced glaucoma. Most of them belong to low socioeconomic status, and the important point in examination was that most of them presented to us with the intraocular pressure within the normal range. So we asked them a set of questions beginning with whether they had any consultation with any eye care practitioner in the past 2 years. A duration of 2 years was chosen because glaucoma being a chronic disease, there must have been some signs suggestive of glaucoma in their previous consultations. So there were 42 patients who had a previous ophthalmic consultation, and out of them, glaucoma had been diagnosed in 23 patients. And the prostaglandin analogs were the most commonly prescribed drugs, and most of them were not using the medications regularly. And the follow-up was also not very regular in most of them. 19 patients who presented with advanced glaucoma to us had consulted an eye care practitioner in the past 2 years, and they had not been diagnosed as glaucoma. So they had consulted either in eye camps or hospitals and clinics, and the most common advice which they had received was regarding cataract surgery, and few of them had been prescribed glasses for near vision. So based on our study, we feel that there is a need to address this issue at various levels, starting from screening. So there is a need to do comprehensive eye examination at all levels of patient contact. Specifically, we have to do an opportunistic screening for more than 40 years patients for whatever reason they present to us with, and patients who have got risk factors have to be screened properly at all ages, and all patients brought from outreach camps have to be screened for glaucoma. These previous landmark studies have also shown that glaucoma diagnosis was missed during ophthalmic examination. Our study done more than 2 decades back sadly points that the situation might not have changed much since then. So out of the various screening modalities, mainly for open-angle glaucoma, optic nerve head examination is the most common reason for suspicion of glaucoma during screening. A study done by Sihota et al. As recently as last year has emphasized on the role of clinical examination of the optic nerve head in glaucoma. It's a very cost-effective way to screen for glaucoma, can be done even without dilatation. A simple 90D lens and a slit lamp is sufficient. And even in the periphery, patients can have their images taken. And if there is any doubt, the images can be sent to experts for opinion. Eye camps have traditionally been very popular as a means to serve the underprivileged. However, in most parts, they are still focused on detection and management of cataracts only. A comprehensive eye examination is often not performed for various reasons, but this gives a false sense of security to the patients of having consulted an eye care practitioner who found nothing wrong with their eyes except probably a need for presbyopic glasses. Such eye camps without a system of comprehensive eye examination should not be promoted. Rather, they should be strongly discouraged. Vision centers have been running successfully in several states, providing permanent access to eye care to the rural communities. There is an urgent need to replicate such models in every other state. Coming to the management part, prostaglandin analogs are the most commonly prescribed drug in our study. A study done by Nayak et al. Found that in the low-income group, the cost of glaucoma therapy may range to as high as 123% of the gross monthly income of the patients. So it is futile to prescribe such glaucoma medications to a patient whose monthly income is less than the monthly expenditure on medications. So we as a society can promote subsidy on glaucoma medications for the low-income group. We can promote use of cost-effective medications, and we can also ensure availability of good quality generic medications. And even primary surgery at presentation may be considered if the diagnosis is confirmed and quality surgery can be assured. So an individualized management depending on the severity, age, socioeconomic status, and likelihood of follow-up would go a long way in curbing this problem. Coming to ophthalmology education, there is this great need to standardize the training programs, reinforce the training at all levels, and inclusion of skin evaluation in PG exam might also help, and a uniform exit exam for PGs may curb the disparity in the quality of training which exists today. Awareness for glaucoma can be increased by promoting health literacy on glaucoma, strengthening initiatives taken by ophthalmic societies on events such as World Glaucoma Week, reinforcing glaucoma detection and proper counseling of patients once they are diagnosed. By strengthening these aspects, we might be able to curb the glaucoma blindness, which is on the rise, at least to some extent. I will leave this question unanswered for each of us to introspect and answer for ourselves. Thank you very much.
Thank you, Dr. Sahab. Very good lecture. Next speaker is Dr. Ashwini Kumar. Sir, you can present from this, sitting from here. ये ले लो, अच्छा cordless है.
Hello, I'm Dr. Ashwini Kumar. I'm doing visual rehabilitation in Bihar, and I'm consultant at Mahavir Netralaya, Patna. So it's a study of the patients. Lot has been said about that. Dr. Parikshit had told you about this. So it's a clinico-social study of low vision treatment at Mahavir Netralaya, Patna. Low vision. धीरे तो बैक कीजिए. नहीं बैक कीजिए, तुरंत आपने हटा दिया, उसे बता देना था. नहीं इसके नेक्स्ट दीजिए, सेकंड दीजिए. इंट्रोडक्शन and significant visual field loss, tunnel vision, lack of vision in the periphery, and blind spots are the examples of visual field loss. Then there is term legal blindness. Then there is disability statistics from the 2014 American Standard says that 2.3% of the individuals ages between 16 and over have a visual difficulty or low vision. Next. So material and methods. The place was Mahavir Netralaya, Patna, and Renu Eye Care at Dr. Prananjan Sir Clinic at Boring Road, Patna. We examined 36 patients because at that time there was very less awareness about it. So the period was December 2018 to April 2019. We took the history, clinical examination was done, and relevant lab investigation was done as well. We did Snellen chart for the distance, and near vision chart, color vision chart was done. With Ishihara chart, we do examine the ocular movement and slit eye examination. So spatial intervention. We introduced newer instruments like monocular and binocular telescope for distance, and for near vision there were handheld magnifier, illuminated and non-illuminated magnifier. There are pocket magnifier, dome magnifier, half eyes and magnifiers and cutaways. Treatment. Different kinds of magnifier were given for the visual correction and improvement. And M training for the patient with peripheral vision loss. M training means patient will rotate his neck to make big capital M so that he can see the periphery when he had the loss of peripheral vision. So he'll just make a big M by rotating his neck. So it's called M training. And there's a notex to recognize the currency. Next. The problems identified were there were 3 patients of retinitis pigmentosa, 1 had coloboma, and 4 had nystagmus, 6 had Stargardt disease, 4 had corneal opacity, and 4 had diabetic retinopathy as well. 1 had amblyopia, 3 were pseudophakic, and 3 had glaucoma, 3 had high myopia, and 4 patients were central serous retinopathy. Next. So the results, there was improvement in the patient from PL/PR to 616/8 patient, counting finger to 616/6 patients, and counting finger to 6/36 in 3 patients, counting fingers to 6/18 in 3 patients, and counting finger to 6/60 to 6/36 in 9 patients. There was no improvement in 4 patients. Total of 36 patients, most were satisfied. There were improvement in quality of life like reading the newspapers, doing home and office work. Child was able to read blackboard and give exams. There was improvement in walking independent through M training, handling money, improvement in household cooking and chores, and including the cutting vegetables, identify species and condiments. Next. Next. So discussion and conclusion. Proper diagnosis, treatment and rehabilitation helps in improving the quality of vision as well as quality of life. The management of low vision needs both visual correction and rehabilitation, which may take several months of practice at home in daily life. Discussion. Low vision correction is a worthwhile investment of time and resources. Thank you.
Thank you, Ashwini. I know that you are doing very good work in your hospital. I have sent you many patients, and they are all have good vision at present. And I think that you should continue this type of work, and you should present in all another conferences.
I want to just tell you one thing. It was your gesture and Pranav sir's gesture that boss gave me the financial support to attend the AIOS annual conference at Mumbai, because I was not able to go there to
Yes.
financially arrange. So
It
they
is-
arranged the money.
Yeah, it is your work that
So
we are
arrange the
forced
money.
to do
They
this
gave me
type of
money.
things.
जाओ भैया जाके present करो paper.
Yes.
बिहार के तरफ से. So it was their gesture. I'm really thankful for my
Yeah.
who gave my life also. So I really need your blessing. Little life.
No, you will continue, and you should continue your low vision work. Yeah, thank you. नहीं, कुछ बोल रहे, ये बोल रहे। नहीं, yes. I think there is now we should end this session, and and all the papers are very good, and now we should conclude this session. But that's okay. It is just before time, but anyone can. Okay, please.